the next question after you've decided to get breast implants, what could go wrong? Now, there's only a very few things that could go wrong with breast implants. Number one, you can get an infection. Infections are so rare, thank goodness. And if you get an infection, the implant has to come out. You have to be treated with antibiotics, and a new implant goes in about 3 months afterwards. And also in my practice, this is very important. Who pays for this redo? Number one, I buy insurance on all my patients, and so if a problem occurs in the first 30 days, the insurance company takes care of it. Number two, my deal with all my patients is if anything goes wrong in the first year, I will take responsibility. I pay for the surgery, I pay for new implants if necessary, I pay for the bra, and even the lab work. The next area that potential problems that could occur is hematoma. I create a space where no space exists. You could bleed into that space. How do we eliminate that? Number one, endoscopic surgery. We see the bleeder, we stop it. Number two, drains. We get rid of that last little bit of blood that's oozing out of capillaries. Number three, my patients take it easy for 3 days. For 72 hours, they don't wash dishes, they don't make beds, they don't drive a car. But at the same time, they don't lay in bed and do nothing, or they'll get clots in their legs. So you're housebound, but you're not bedbound for 3 days. The third potential complication area is malpositioning, breast implants that are too high, too low, too far to the sides. And remember, I told you that if I have a complication, I have to fix it on my dime. And as much as I love my patients, I prefer not doing free surgeries. Therefore, I never let the patient leave the operating room until the breasts are symmetrical. And I've got this magical instrument. It's called a ruler. New thing. You may not have heard of it. Yeah, just kidding. I have a metal ruler, and I measure from the bottom of the breast to the nipple. Now, two breasts very often are not exactly at the same position, and we make them as close as possible with keeping the nipples looking good. Normally, and I discuss this with my patients, normally we want the nipples as much as possible on the same level, not the bottoms of the breasts. So you can't get everything, so we go for the best look with nipples at the same level. But if the implants or the breasts are malpositioned more than they should be, tiny bits of asymmetry that are acceptable, then they have to be fixed, and I fix them. The next potential area is loss of nipple sensation. Again, nipple sensation comes from a nerve that comes from here laterally up to the nipple, and it's the between the fourth and fifth intercostal nerve. And that nerve is very often injured when you make an inframammary incision. It's sometimes injured when you make a periareolar incision. It's almost never injured when you go in through the armpit. So going into the armpit underneath the muscle gives you the greatest chance of no loss of sensation. And I have a very great track record of not losing nipple sensation. And it's because of the route of entry, because we handle tissue delicately, and because it's just the right way to go in.